Okay, let's go ahead and get started. Welcome everyone to the Medical Advisory Subcommittee for Wednesday, March 9th, 2022. We'll go ahead and call the meeting to order, and we'll start with introductions. I'm John Burley, EMS Medical Director for Monterey County.
Teresa Rios, EMS Director.
Tina Nieto, Monterey County Law Chiefs.
Steve Brooks, EMS Agency Staff.
Kimberly Hernandez, EMS Analyst.
Deborah Hopgood, EMS Agency.
Sorry, Deborah.
Sorry, Roxanne.
It's okay. We went at the same time. Roxanne Supersad, EMS Agency.
Michelle Kalinsky, Chomp.
Christy Sobolewski, Chomp.
Morning,
Vicky
Jeff
Wallace,
Horner.
May Memorial.
Jeff Horner with Telstar. Good morning.
Cassie Caldera, Natividad.
Ben Hitchcock, AMR-CES.
Will Hiller, AMR.
Okay, very good. Well, welcome everyone, and thank you for being here this morning. I'm going to just go ahead and start the meeting off in recognition of the fact that on February 25th, Salinas police officer Jorge Alvarado was, as you all well know, shot and killed in the line of duty. This is a moment of great sadness for his family and the broader community of law enforcement officers, the EMS providers, firefighters, and hospital personnel who worked with him and knew him. As you know, there will be a public memorial tomorrow at Rabobank Stadium at 10 a.m. and I encourage everyone to attend if you can. Our thoughts and prayers go out to his family, to the members of the Salinas Police Department, to Chief Nieto, and the broader law enforcement community, and to everyone who knew Officer Alvarado. I think I was just struck this morning in thinking about it that, you know, as a police officer, you're part of a family that goes on and without end. And so in that context, I'd like to take a moment of silence in memory of Officer Alvarado and the sacrifice that he made for his community. Thank you. We'll go on with the first official item agenda, which is public comment. It's an opportunity for anyone to make comment to the committee. Okay, hearing none, we'll move on to the next item on the agenda. Sorry, one QA. Hi, Chief Boyd. We'll go ahead and move on to the next item on the agenda, which is approval of past MAC meeting minutes. And we have meeting minutes for January 12, 2022 from our MAC meeting. And we also have meeting minutes from our special meeting minutes from February 9th, 2022. So can I get a motion to approve the minutes from those meetings?
Tina Nieto, I move to approve both meetings.
Jeff Warner, a second.
Thank you. And so we'll go ahead and take a roll call vote on approval of the meeting minutes.
Dr. Kalinsky,
Aye.
Dr. Orchard,
Aye.
Dr. Greenson,
Aye.
Christy Sobolewski,
Aye.
Tiffany Wallace,
Aye.
Cassie Caldera,
Aye.
Will Hiller.
Aye.
Jeff Horner
Aye.
and Tina Nieto.
Aye.
Are there any committee members that I may have missed in there? All right, looks like that's everyone, Dr. Burley.
Okay, thanks, Deborah. That'll bring us on to correspondence, and there's no specific correspondence for today's meeting, which brings us to reports. And Teresa Rios has a report for the EMS agency updates.
Thank you, Dr. Burley. Your packets include a staff report that outlines some of the work that the EMS agency has been engaged in since, in the last couple months. Just to provide us some highlights, our 2022 policy and protocol update, we're almost at the end of that cycle. As you know, when we started, we committed to improving our processes. This is a big one that we really want to fine tune, and we continue to do that. The changes that we have made, we continue to reach out to the stakeholders just to get the input. And so far, we have received positive feedback regarding the changes. We have taken their input before we make the changes, and I think that that's working well. I don't want to go into the detail because Steve has a presentation about that, but it is. I think that the changes are substantial and they are going to benefit the system. So I'm excited about this one. Another highlight is the paramedic training program. We, as a staff report says, we are working with a consortium of community colleges to establish a paramedic training program in Monterey County. We're still in the initial stages, but this will allow us to have a functioning program in Monterey County. As everybody knows, there's a shortage of paramedics everywhere, and so hopefully this will help us to stabilize that. Another exciting project is that we are looking at a public access AED tracking and use software. We connected with an organization that has a mobile app, is already working with other LEMSAs, and we're exploring that opportunity. We hope to implement it. It is at no cost to the agency. At least one piece is at no cost to the agency, and this organization also provides assistance with marketing campaigns, which I think that would be great for us to do. So internally, we're kind of getting our ducks in a row on how to do this. And the person we'll be talking to is going to give a presentation at EMCC, and we're going to move forward from there. we have reported before that we had applied for the EMSA, the state agency, had made some funding available to offset costs of training personnel on the COVID vaccine. We applied for it. We have not received the funds, but of course the funding would be distributed among those entities that are participated in the COVID vaccine. But we checked on that just a couple of weeks ago. Deborah can correct me on that. And they still have not released the funds. So as soon as they are released, based on the proportion, we'll be able to figure out based on who applied and how, and the cost that was reported will be distributed accordingly. One thing that is not on the report that I wanna let everybody know is that we have started to work with AMR on revamping the way that we do community education. You know, there's language in the agreement that says, you know, you have to do this many hours, and of course it's based on what was happening at the time, you know, some 12 years ago. We want to join the current century and take advantage of all that social media opportunities that we have. We hope to by May have something put together. So that is in the works. I don't have a lot of information because we just started working on this, but something that is going to be coming to the board. We're excited about it. We had a meeting about it yesterday, and I think that it is time, you know, that we do more than just at least for the EMS agency. We maintain our website and our Facebook account, but we want to take advantage of what is out there, and especially campaigns that AMR already has used, and see how we can make them our own, and start putting those out. The last thing is that in May we'll be giving the board of supervisors an annual report. Last year, the first time that we did an actual presentation to the board on the accomplishments of the EMS system. We plan to do the same this year. We take advantage of EMS Week to do the resolution and then to go and give the report to the board. Last year, the report, Dr. Burley and I did the presentation. It was very well received. I think Board of Supervisors learned something from the presentation, and they realized just how much work is done in EMS. I think they have some knowledge of just pieces of the system, but to bring this presentation and highlight all of the different parts of this system was very helpful. So we are planning to do the same this year. So we're going to start working on putting together our annual report and making sure that we are on the schedule for the board meeting during EMS Week. And that's the end of my report. I'm happy to answer any questions you may have.
Okay, thank you, Teresa. The next item on the agenda is a MOAC activities report from Deborah Hopgood.
Good morning, everybody. There is a written report included in your agenda packet as well, if you need to reference that. January and early February were very busy for the MOAC. Lots of requests for staffing, supplies, testing supplies in particular. It started to taper off a little bit since the end of, since mid-February or so. We've seen fewer requests coming in. And as you might imagine, the data has improved as well. So the data included in your agenda packet is from our meetings on February 28th. I have an update verbally on the latest data, which came out Monday on the 7th. So as of Monday, the case rate was down to 11.4 per 100,000. Test positivity was at 4.3%. And we're down to 20 hospitalized, with 2 in the ICU and 1 on a ventilator. So significant improvements from even just a week prior. So that's really great to see. Vaccination numbers haven't changed significantly. We're at 83% of the eligible population in Monterey having received at least 1 dose and 75% being fully vaccinated. Related to vaccine administration, we received a communication from EMSA late last week that discusses an end to our local scope of practice related to vaccine administration and testing that are currently in place. We're reviewing that and reviewing our internal policies and protocols, and we'll be putting out a communication to all of our stakeholders regarding the termination of those LOSOPs. So more to come on that as we complete our internal review of what's affected. We've been continuing to work on fulfilling PPE requests as they come in. We've also been working on monoclonal antibody requests and antiviral therapeutics, both the distribution and making sure our local facilities are registered and set up to receive those. EMSA recently announced an end to the medical surge coordination calls that I've previously mentioned. I just wanted to say thank you to all of the facilities and to the transport providers who provided us with information that we needed to report to EMSA during the time that those calls were going on. That's all of the update that I have, but I'm happy to answer any questions that anyone may have.
Perfect. Thank you, Deborah. The next item on the agenda is ambulance patient offload times, and Kimberly Hernandez has a report for that.
Okay, thank you, Dr. Burley. Let me just share my screen. Can everyone see my screen? Okay, thank you.
Yes.
Okay, for APOT times, so we're looking at December and January. October and November were reported at the January meeting. In December, APOT times were stable throughout. So the screen you're seeing right now is the average, and then I'll go to the 90th percentile. APOT times were stable throughout in December and showed a decrease at SVMH and Natividad. And in January, APOT times increased at SVMH, Natividad, and me, which is not surprising given COVID cases were increasing significantly through the month. Even with the increases, all of the hospitals did a great job overall in getting patients offloaded from the ambulance crews, so those ambulances could get back into the system to take the next call. Any questions on the APOT times or report? All right, that's all I have.
Thank you, Kimberly. The next item on the agenda is the 2022 policy protocol cycle, and Steve Brooks has something for us on that.
Good morning. Hopefully all of you are doing well. This is actually a really exciting time for us when we are hitting the home stretch on the policy and protocol cycle, and this meeting is actually one of the key dates. Something I'd like to share with you, and I'm going to give me a moment while I share my screen. One of the things that we are most proud of for this policy cycle is the process that we've taken. We've extended the process. We started earlier. We've included many more opportunities for input. And so we'd just like to go over the process a little bit with you. Again, we're very proud of it. So the scope of the process, you can see that we had 68 policies and protocols that we've touched on in this process. Fortunately, almost half of them have had very little to no revision, administrative changes, grammar, where we thought the language wasn't necessarily as clear as it should be, so we changed a few words, and some minor format changes. Then we had another 24 policies and protocols that received some significant changes. A lot of it was just format, where we've moved protocols from a list format to a algorithm flowchart format. But there was, some minor adjustments in what we wanted the policy or the protocol to indicate. Then we had some significantly revised policies and protocols where the whole thing was either revamped or it was added with new direction, new information, just big changes. So there were some of those. And then of course we had one policy that was felt to be unnecessary. It was really covered better in a different policy. So that's kind of the scope of the whole thing we've been doing for almost the last year. And as I said, we've really tried to encourage and improve the interaction of the stakeholders, this committee included. So as you can see, we started way back at MAC in September of 2021, where we brought as the agency to MAC the launch of the cycle and requested that any policies or protocols that members felt didn't address or were adequate for our needs to let us know about those. So we left that process open for almost a month from September to the 1st of October. And then the EMS agency put together the policies and protocols that we were bringing forward and started the public comment period in October. And that ran all the way through November 19th. For those who've paid attention, we've had the public comment period in the past run over the holidays, the Thanksgiving, Christmas holidays. So we've pushed that up a little bit so that we weren't expecting people to take what is hopefully time with their families and other holiday activities to feel like they needed to do the public comments. So we did that. We also opened up some in-person, if you will, meetings. Unfortunately, they had to be done by Zoom, but we had 4 of these meetings where people could drop in and comment on the policies. We've taken our policies to specific groups like CQI TAG and TQuick. We had a training officer review. And these are the people who are going to be going back to their organizations to do the training. So we gave the updates to them to look over that, as well as the training materials. And we received some good feedback, especially at the meeting we held with them on the 25th of February. And then, of course, we brought the public comments to MAC on January 12th of 2022 and received feedback there. All our committees, we made sure that they were kept abreast of the process or at least had opportunities to comment. So you can see where we've come to MAC and Ops, updating the process, where we went to CQI TAG and TQuick to share with them and get their feedback. And then, of course, where do we go from here? Well, next we're going to be looking for endorsement of the policies by this body. That's today. We will be sending them to the app developer. In fact, we've already started the process of getting them to the app developer so we can have the app updated and released, before the policies are in effect. And then we will be distributing the policies in their final training draft form for training purposes on April 1st of 2022. And then, of course, the final version will be updated to our website before the July 1 start date. And thank you for that. If there's any questions about the process, be happy to answer that. Otherwise, I'm going to stop sharing my screen and move to the next part, which is, as you see on the staff report for this item, the EMS agency is asking MAC to endorse the policies and protocols, and we can move forward with them. And that we've
There's a
distributed
question.
them. I'm sorry.
Dr. Kalinsky has her
Yes.
hand raised.
Dr. Kalinsky, feel free.
Hey, I was looking through the final versions and I just had a couple questions. Will we be looking at any of the individual changes that were made after the last versions or no?
If you if you have a question for that would affect endorsement, please, absolutely, we need to
Okay.
make sure that you're comfortable with whatever. So yes, if you have a question, please ask.
So the chest pain treatment policy, I saw that it previously sublingual was used and then only for prolonged transports was nitro-paste advocated. And I see now that it's listed as an either or without the initial administration of sublingual. The pharmacodynamics on nitro-paste, some of them absorb pretty quickly, but others say that there could be a 30-minute delay in it being active therapeutically. So it's not usually the primary thing. Can we do that as a kind of post for long transports like we previously had, or do we really want that as a primary administration?
Give me a second, I'm gonna pull up the policy and Just waiting for the document to open, then I'll share the screen. Okay, so here's probably while I scroll down. There we go. Dr. Burley, would you like to comment?
Do you want to share your screen, Steve?
Oh, did I not? Pardon me. There we go. Sorry. One additional button to click. So this is the flow chart in the chest pain. And here's where it's one or the other.
I mean, I think the original indication that we were mostly concerned with NitroPaste was having the ability to use it when patients are on CPAP for CHF as an adjunct. But we also previously, when we were talking about it, said, yeah, you know, long transports going to a STEMI center, it's not unreasonable to put it on. But as a primary drug, you know, the pharmacodynamics of the absorption are far less consistent than the sublingual. And when you're talking about a patient that you want to get medications into rapidly that work, it just seems like it would be better to stick with the sublinguals as your first line agent.
What would your suggestion be for verbiage here, Dr. Kalinsky?
I would just kind of move to put it in parentheses, maybe used for prolonged transport or CPAP or something like that. I don't know. It just, I don't think the original policy was written that way, but and I think we also allowed higher dosing.
Right, so kind of in parenthetically for the NitroPaste, you'd say consider adding NitroPaste for prolonged transports or for patients with CPAP on CPAP.
Yeah, but leave it as, you know, the nitro sublingual as the primary mode of administration.
Mhm.
Does this address your concern with that change, taking out or and then consider?
Yeah, yeah. I'm what I worry is it's so easy to use and you don't have to redose that rather than using something that's going to work immediately, they're going to say, oh, I have this as an option, put on the NitroPaste, and then it's going to be a half an hour before it reaches any pharmacodynamic activity of significance in some patients.
If this works, then we've made that update.
Perfect.
Dr. Burley, are you good with it?
Yeah, that's fine with me.
All right. Anything else on this protocol?
No, not on that one. The only other
All right.
real question that I had was in terms of like clinical management is your ROSC protocol. I'm a little concerned with the bifurcation for the hypotensive ones having a pulse of 60 leading to atropine and pacing only, because there are so many sinus bradycardia pulses less than 60 that don't need atropine or pacing. They're an inferior MI and they need a little bit of fluid and to get to the STEMI center. And I don't really want, you know, atropine and pacing considered the treatment down that pathway line. And right now the pathway divides such that, you know, you're not administering fluids or pressors. Really that pulse less than 60 should be, you know, either far less than 60 or heart block or something that's going to respond to atropine and pacing. I know pacing says if indicated, but just the way the bifurcation reads on that one, it would be nice to clean that up.
So a suggested change to the verbiage here, would you recommend changing the pulse rate to less than 45 or like kind of?
Or significant heart block dysrhythmia, you know, and I also would still put fluid in that side of the algorithm as well, because right now fluid and pressors are completely separate and almost like not allowed under that side of the algorithm, the way it reads. So there should be some crossover, right? The hypotensive patient with the heart rate of 40 probably needs atropine and fluids potentially. Or, you know, if they're a sinus Brady at 35, but if they're in heart block, they need pacing. But the way it reads now, it's like if it's less than 60, I mean, I could have a sinus Brady at 58 and it would put me giving atropine and pacing when really all they need is fluid for their STEMI. So somehow allowing a crossover of an and, you know, I don't think in most cases a fluid bolus of 500 mLs is going to hurt these folks.
Yeah, I have no problem adding fluid, basically in the same format as the line to the right. You could have fluid bolus 500 mLs below the pulse. And then if you like, we can just adjust that pulse rate to something a little lower than it currently is.
Yeah, or heart block. Just because there's so many people on that are cardiac patients on calcium channel blockers, beta blockers on purpose to make them bradycardic. It's not the source of their issue. And, you know, putting them down the wrong pathway at a heart rate between 50 and 60 doesn't make a lot of sense.
So do you want this heart rate to be lower?
I personally would, or heart block. I mean, a significant second or third degree heart block would take you down that pathway, right?
Right. What if we have heart rate less than 60 or second degree or third degree AV block? Right, pulse less than 50.
Yeah, 50 is probably a little more reasonable.
Pulse less than 50 or second degree or third degree AV block.
And then at what point do you add pressors into this part of the algorithm? Because right now there's no crossover. So, you know, are they gonna, if we give atropine a few times and they're still hypotensive, when do we cross back in and start, you know, loading the pressors on long transports? As a matter of fact, I don't think we use dopamine very much at all, but.
Right, we usually don't.
But if we're gonna have it on there, when do we make that switch, I guess is what I'm asking.
Mhm. You'd probably
Versus larger fluid bolus or.
Yeah, you probably add dopamine if your other interventions are failing. So it'd be kind of at the end after atropine if we're going to add it here.
Would you like it copied from here to here?
But yeah, since we're saying consider dopamine, it doesn't mandate it, but as you say, it's not something that we use a lot in the field, but it would be reasonable to bring it into this side as well for patients that are unresponsive to atropine or pacing.
Okay, I'll connect it into there.
Okay, great.
Is this good?
Yeah, I think that clarifies. I was just looking at it going, okay, so I'm not sure what to do if I got a heart rate of 55 and a blood pressure of 90 under this and it's a sinus Brady. For me, I wouldn't go down this pathway, but there's no other path for me to go down.
Mhm.
So I think that fixes that portion of it. You had a couple mild typos on one, but there's only one other that I had a question on, and it's more due to kind of stalking and where it falls. In your hypothermia protocols, you have it for dextrose 50% up to 25 grams. I would say, I mean, hypoglycemia is already going to refer to your hypoglycemic protocol. If you want to leave it, that's fine, but I don't think that's your only stock. And so by writing the protocol in that way, it kind of ties things a little bit. So it seems to me that you'd either want to, I mean, they're going to check a sugar and presumably end up in a hypoglycemia protocol. So maybe that box just doesn't need to be there. If you want to keep it there, I would probably keep it consistent with the hypoglycemia protocol, so it's not different. Oh, hang on, this is not the one. Maybe I
Are you looking at the pediatric one then?
Oh, give me a second. I'm gonna have to go through and find the actual form that I found because I took a screenshot of it and I thought it was the hypothermia. Maybe it is the peds one. And I'm gonna have to scroll down your 211 page one.
That's why I'm bringing them up for you.
Oh my goodness.
I'm
gracious.
prepared for this.
Yeah.
Steve, while we're looking for that,
I mean, this is a pretty simple switch for you guys. I just think that it makes more sense to refer to your other policy that clearly outlines all of the options rather than tie yourself into a drug that's frequently not available and not
I think
necessarily consistent with your other outline.
Yeah.
This is
I
Derek
don't think
Orchard. It's under the hyperthermia one.
Hyperthermia. Okay,
Okay, sorry.
that's okay.
You're right. It says prevent shivering. I should have looked up further. That's what I get for taking screenshots.
Well, we appreciate your eye. And so you're talking down here about the administration of dextrose?
Right. But you have a hypoglycemia policy that doesn't mandate D50, which is frequently unavailable. And so, I mean, I think honestly, if you have your glucose check and you have it up above, they're gonna, if they get hypoglycemia, refer to that protocol. So maybe you can just get rid of that box.
or you could just add, change the
Sure.
verbiage to, treat hypoglycemia according to the hypoglycemia policy or for BGL less than 80, refer to hypoglycemia policy, something along those lines.
So I kind of feel like the hypoglycemia treatment should be one of the first things and not necessarily fall behind cooling measures and things like that. Because, I mean, if you've got a sugar of 30, that needs to be way up high on your algorithm, right? And you checked it way up high. Maybe just put it in that upper box where it says, check glucose, treat per protocol.
So how about consider dextrose for blood glucose,
I don't think you consider it. I think you administer. But what I'm saying is up above, you have them checking the sugar, maybe put, less than 80 treat per protocol up there in the upper box on the top. Don't you have it checked? Yeah, assess glucose level.
Yeah, what you could do, Steve, is just say, assess glucose level and administer dextrose for BG less than 80.
and you want that up here?
Yeah, I think that would be, that allows you to treat it early in the protocol, and then we can get rid of that lower box.
So what language did you want to put in there? Assess blood glucose level.
And administer dextrose for BGL less than or equal to 80 milligrams per deciliter.
less than 80 mg per GL. Like that.
Yeah.
And then I'll fix it up and
Then
then
you
we'll
can get
remove
rid of that
this
box.
box. Okay,
Do you want to know the two typos? They're not clinically relevant, but they're there.
Sure.
which are they in?
Principles of sepsis box.
All right, give me a second.
You save that one, Steve?
Yes.
Okay.
Oh, yeah. And sepsis?
Yeah. Down at the bottom box on the left, the principles of sepsis, the final dot, it's early recognition of these, I think, not the, THEE. Right, there should be an S.
We were,
The
Early
principles
yeah.
of sepsis, bottom box, final
Right.
bullet point, early recognition and treatment
of these patients, right? I think Steve was going for Shakespearean English actually there.
That's what I was figuring. I was like looking going,
Okay. Is there another typo in this one?
no, not at all.
Okay,
Not at all.
thank you.
Oh, and I don't know if this is a peds or adult one.
Which
I'll
one?
look it up and I'll email you if I find it.
Okay.
'Cause the screenshot cut off and I can't tell if it's peds or adult.
That's fine. But if you let me know today, that'd be great.
There's nothing else clinical that I had outside of the chest pain in that ROSC one.
Steve, can you go back to the chest pain for just a second? The algorithm. Where did we, sorry, maybe it's the bradycardia, where we made our change to from less than 60 to,
That's the
That's
ROSC.
great. That
sorry,
was the ROSC.
Rosk, sorry about that. The only thing I was thinking of here is that, so now we have a bifurcation that says pulse less than 50, and then the other side says pulse greater than 60. So we're not really addressing patients between 50 and 60. And so we may want to change that one on the right to say pulse greater than 50 instead of pulse greater than 60.
Of course, because it wouldn't be bradycardic. But this is ROSC, so. But if you're, yeah,
You see, just so we,
Yep. oops,
or greater than 650 is good too.
yes,
There we go. Great.
okay.
Yep.
Does anybody else have anything that they think should be reviewed before we talk about endorsement? Excellent. Then the EMS
Before-
agency staff is, oh,
Hold on one second. Before you move to endorsement, the only thing I want to add is that in the next cycle, we're already starting the next cycle, the 2023 policy and protocol cycle. We did that very intentionally. I want to just provide a little more detail than what Steve provided. We want to start now so that we can gain more time for the review. We've heard your feedback that the review of the policies and protocols is intensive, especially with the number of policies that we have to review each cycle. So by starting our internal process now, we are gaining about 4 or 5 months of the process, which will allow us to extend the review public comment phase of the process. We've also taken a look at all of the policies and protocols, which we have about 155. And we, to the best of our abilities, we have divided those, equally among the 3-year cycle. 2022 had 68 policies and protocols that we had to review. That was a lot. A lot of them needed to be reviewed, but we want to make sure that we keep them on that 3-year cycle. For us to complete the review, we have to review about 52 policies per year. So not unless we extend it, that we change that 3-year review cycle, which I don't think is a good idea. Then that is the number of policies that we would have to review each year, as you saw from the report that Steve gave. A lot of them don't need any changes, or they result in just minor changes. So I wanted to just add that to the information that Steve provided, and you should be seeing something from us in terms of the 2023 policy cycle very soon.
Okay, well, excellent. Thank you, Steve. And let's go ahead then and move on to the endorsement for the 2022 policy protocol cycle. If we can get a first and second for that.
Tina Nieto, I move to adopt the policy cycle.
Michelle Kalinsky, I'll second.
Thank you.
Dr. Burley,
Yes.
if I could.
Go ahead.
Because of the motion that was made, I want to be clear because staff is, going to follow the direction. So Chief Nieto, appreciate the, adoption of the cycle. We're hoping that we get endorsement of these policies as opposed to what I call the process. If you understand how you stated, I just want to make sure that we're clear that the policies receive endorsement and we will move forward in implementing them.
What
Yeah,
Steve just said
in addition,
for the motion.
I'm sorry.
Thank
I'm
you.
sorry,
I'll
Chief-
second
Chief
that.
Nieto. Yeah, just a second, please. The motion needs to include the changes that were made today, because the policies are different than what went out with the
Yes.
agenda. So the motion should say approve the policies with the changes made.
Right, so it will be a motion to endorse the 2022 policy and protocol, including the changes that were made today at the MAC meeting. How's that sound?
And also with what Chief Nieto said, the policy cycle process is something to move forward with too.
All right, I move to endorse the policy procedures that we just talked about, and whatever language you need to add, Steve, into that, and also endorse our the cycle with the changes that were discussed earlier as we discussed this item. So there were a few changes. So
Second.
Okay, thank you. Let's go ahead and take a roll call vote on that.
All right, Dr. Kalinsky,
Aye.
Dr. Orchard,
Aye.
Dr. Greenson,
Aye.
Christy Soboleski,
Aye.
Tiffany Wallace,
Aye.
Cassie Caldera,
Aye.
Will Hiller.
Aye.
Jeff Warner,
Aye.
Tina Nieto,
sorry, aye.
thank you. Any committee members that I may have missed joining late? All right, I don't see any on the list.
Okay, so thank you all. Motion carries, and we'll go ahead and incorporate those changes that we discussed today. thank you again for everyone's input. It really helps with the process, and we enjoy working with you all, and look forward to as we finish the 2022 policy and protocol revisions. We look forward to getting started on 2023. But hopefully adding the additional months will give us all a little bit more breathing room and more space for public comment and additional input. So thank you all for that. That'll move us on to new business on the agenda, and the first item under new business is MAC membership updates. And Deborah, you have the floor.
Thank you. You'll find a staff report on MAC membership updates in the agenda packet as well. The MAC membership term is for 2 years and expires on June 30th. So we have 7 members who have terms that are expiring on June 30th, 2022. So the list is provided in the agenda packet of those members and their names. We'll be reaching out to those members to ascertain their interest in continuing to serve as members of the MAC subcommittee. And we plan on bringing nominations to providing a report on appointments at the next MAC meeting in May. So in other news, Will Nealand has joined us as a new representative to the MAC committee. He's from Monterey County Regional Fire. He'll be representing field staff of paramedic service providers other than the contracted ambulance provider. And then we also have Ben Hitchcock, who has been nominated to replace Will Hiller as our representative for the county's primary ambulance contractor. Those nominations will be going to EMCC today for endorsement, and we'll be having those members join us in the future.
Excellent. Thank you, Deborah. The next item on the agenda is base hospital physician training, and that one's mine. So as most of you know, we've been, the EMS agency has been putting together a PowerPoint module and training for base hospital physicians, just to kind of, sort of give physicians serving as at base hospitals a broader understanding and context of the EMS system, their responsibilities as base hospital physicians, and also to give some guidance and overview of several special circumstances that they may encounter in the base hospital consultation process. So I've put together a presentation for that, which was sent to CQI TAG, and which I will be presenting on, I believe it is March 29th at 1:30 p.m. Is that correct, Deborah? Yeah. So March 29th at 1:30 p.m. It'll be an online presentation that I'll go over, and then we'll also make that available on the website so that when new physicians are onboarded at base hospitals, that's available for review. It won't be overly extensive, and hopefully it'll be kind of fun and a good resource for folks. So that is on the imminent horizon. Any questions about that item? Okay. The next item on the agenda is triage tag days, and Steve Brooks has a report on that.
Hi, welcome. Good morning again. And through the, pardon me, through the UO process, we actually reviewed an MCI, and one of the issues that were brought up is that triage tags were not used, even though there were 10 people involved in this traffic collision. The tracking of the patients, sorting of the patients probably would have benefited from use of triage tags, would have helped everyone know the priority of the patients. The care all seemed fine, but we think that the process could have been done better. And we also are thinking that maybe without frequent use of triage tags, our field providers don't think about using them at the time that they should be used. So several years ago, we had had a regular triage tag training day where triage tags were placed on every patient. So the EMS agency is looking at reestablishing something like that, where we do regular use of triage tags so that our staff, as far as our EMS system personnel, are familiar with the tag, and it's at the top of their mind when there are multiple patients. And then we also used it as a tool to ensure that we were able to track patients through the hospital experience. So from the field, using the triage tag number to the patient's final destination, whether it's within the hospital, discharged, transferred, whatever, we would know where that patient ended up and could track that patient. So EMS agency is working on something like that, and you'll be hearing more about it in the future.
Okay, thank you, Steve. And then Deborah has an item, the next item on the agenda, which is AB 361 requirements for remote meetings.
And this is essentially our ongoing need to reevaluate every 30 days whether or not the conditions still exist to continue meeting remotely. So if the committee feels that those conditions are still in place, we would need a motion to continue with our remote meetings in a second.
Jeff Horner, I'll make a motion.
Will Hiller, I'll second it.
Okay, so thank you. We have a motion on the floor to continue our remote meetings under AB 361 requirements. We'll go ahead and take that to a roll call vote.
Okay. Dr. Kalinsky?
Aye.
Dr. Orchard?
Aye.
Dr. Greenson?
Aye.
Christy Sobolewski?
Aye.
Tiffany Wallace? Cassie Caldera?
Aye.
Will Hiller?
Aye.
Jeff Horner?
Aye.
Tina Nieto?
Aye.
And back to Tiffany Wallace.
Okay. So the motion carries. Thank you all. And then Deborah, you also have the next bullet point under this agenda item.
Yes. So as I mentioned before, we need to meet every 30 days to reconsider this. So given the schedule of the MAC subcommittee meetings, we will need to meet again, actually twice before our next regularly scheduled meeting. So our recommendation from the EMS agency is that we hold a meeting on Wednesday, April 6th. That will be another one of those short 5 to 10 minute meetings to again reconsider this item. So please reach out to me if you have any conflicts with that meeting time suggestion. Otherwise, we'll go ahead and plan on one of those short special meetings for that time.
Okay, great. Thank you, Deborah. And that brings us on to the next item on the agenda, which is EMS System Quality Improvement Program. And under that, the CQI tag report.
All right. As you heard, a significant portion of our time and attention has been devoted to the policy and protocol cycle recently, as with all of the efforts that Steve outlined earlier. So in addition to that, we did hold meetings of all 4 of our QI groups in February. The stroke and STEMI committees discussed some overall system functions and concerns, and they also both conducted case reviews. During TQIC, we had a presentation that was great from Dr. Hahn, who's a neurosurgeon at Atividad. He presented information related to patients on anticoagulant and antiplatelet therapy who sustained head trauma. And that came about as a discussion at another TQIC meeting related to our trauma triage criteria. After the information presented, we decided that no changes at this time are necessary for our trauma triage criteria. In CQI TAG, we reviewed the presentation that Dr. Burley mentioned earlier on training for base hospital physicians. And we also spent some time reviewing the initial ketamine data from our first month of administration. So the data from that was overall very positive with good documentations of weights and conditions and a little bit of work to do with documentation of pain scales. So we'll be communicating that information out to our stakeholders and looking for those areas of improvement as well, and continuing to monitor that in our future CQI TAG meetings. So since our last MAC meeting, we did get approval for the American Heart Association Get With The Guidelines agreements. And again, those give us access to the hospital stroke and STEMI data directly. So AHA is now going back to Salinas Valley Memorial and Community Hospital to CHOMP to complete some data sharing agreements that will formalize our ability to access their data within the system. So that is in progress. And we hope that that will significantly decrease our ask for information from the hospitals. We are also continuing to work on the health data exchange items. So we're working with ESO to modify our agreements that will let us expand to the rest of the facilities in the county. So once those are completed, we'll be able to have the facilities placed in a queue for implementation. Also in the CQI TAG written report is a link to the registration for Dr. Burley's class that's coming up and the dates of our upcoming meetings for our quality improvement committees. That's all that I have in the report. If anybody has any questions, I'd be happy to answer them.
Okay, thank you, Deborah. That brings us to any future agenda items that we'd like to discuss at future meetings. Anyone have any suggestions for future items to go on the agenda for our next MAC meeting?
This is Will Hiller from AMR. I just was curious about an update for the next meeting on the data sharing agreement with ESO and the other hospitals as well.
Okay, thank you, Will. We'll put that on the agenda for our next meeting. Any other future agenda items? Okay, hearing none, we'll move on to any announcements for good of the order. Any member of the committee may make announcements or comments, and MAC may not discuss or take any action on these items raised during the announcements, except to decide whether to place the matter on a subsequent agenda. So any announcements or good of the order comments? Okay, very good. And that brings us
Chief
to
Nieto, I don't think we could hear you. There
Oh,
you
Hi,
go.
sorry,
Go ahead, Chief.
sorry, Dr. Burley.
Go
I
ahead.
had a double mute button. Hi, Tina Nieto from County Law Chiefs. I just wanted to announce that Marina Police Department is going to be purchasing a mobile TrueNarc machine. So it'll probably benefit more of the peninsula. I know Chomp has one there that the cops can bring, but we're going to have one that's going to be out in the field. So that's just a test for drug substances. So.
Great, thank you. Any other announcements? Okay, thank you. And then, so our next meeting date, the next special meeting of the Medical Advisory Committee to reconsider AB 361 remote meeting requirements is tentatively scheduled for Wednesday, April 6th at 9:15 a.m. Location and Zoom information to follow. And then the next regularly scheduled Medical Advisory Committee meeting is scheduled for Wednesday, May 11th at 8:30 a.m. And again, location and Zoom information to follow. So those are our upcoming meetings, and that brings us to the end of our agenda. And so we'll go ahead and adjourn. Thank you all for being here, and we look forward to rejoining many of you at EMCC.
Thank you.
Thank you.
Thanks.
Have a good day.